Well, hey there, everybody, and a very happy good evening to you. My name is Dr. Randy Fink. It's top of the hour, and it is time for Fertility with Fink. There is one place that you need to be right now every Tuesday evening. We are back here, same spot, 4 o'clock in the mountains, 6 o'clock on the East Coast, and 3 on the West Coast. Fertility with Fink is the place that you come and I come every week where we can get together and talk about all those things that are important to us. Things like having a family, making a family, things about women's health, and all the things that we are just going through in our lives right now in order to be able to get there. So happy to see everybody tonight, as is every week. I am live this evening from home base in Pensacola, Florida, where I am a fertility gynecologist here at New Life Fertility. Our website is fertilityleaders.com, fertilityleaders.com. And yes, we are happy to have consultations with everybody all over this great world of ours. All you have to do is pick up the phone and give us a call. I also work with my friends at the Missouri Center for Reproductive Medicine, MCRM, in St. Louis and in Tulsa, and where I will be this weekend in St. Louis. I was in Tulsa last week doing some wonderful transfers, so hopefully people are going to be getting some nice positive pregnancy tests in the next few days. But this weekend at MCRM, and next weekend, or rather next week, we've got retrievals for IVF right here at New Life Fertility in Pensacola. So how was your week? You know, we were supposed to get a whole bunch of snow this past weekend here in Pensacola last year. If you don't know it, there was about 8 inches of snow. You might see pictures, of it's actually snowing on the beach and that kind of thing. So it's sort of a once in a lifetime sort of experience. And so there was all this hoopla and fanfare and great excitement over the possibility that it might do that same thing again. And guess what? It didn't. So instead, I was able to look across the street and appreciate a little bit of frost on the neighbor's roof, and that was really kind of about it. So, but you may know that I moved here from Colorado. So we got our fill of snow in Colorado, which is a lovely place to be. I can remember kind of growing up. I grew up in this part of the country and sort of being on the Gulf Coast in Mobile, Alabama, being with in my grandparents' house. Maybe being 7 or 8 years old and actually making a snowman in the yard. And I want to say that may have actually been the last time it snowed with any kind of significance enough so that people could actually build a snowman until last year. And that was very exciting for everybody. But to be honest with you, I don't know if that sort of thing is going to happen again. We've got a few different feeds going on here tonight. We've got my Instagram feed, which is right here, Randy Fink MD. Thank you very much for following me on Instagram. We've got Facebook for New Life Fertility, as well as for MCRM. We've got LinkedIn, we've got YouTube, and here we've got New Life Fertility's Instagram. We just have to need another device here so we can do Instagram for MCRM as well. And I keep thinking, I should do this on TikTok also, but just kind of have to figure out how to get there. Let's say hi. We've got Sheila and Miss Anwar. Hello. Nice to see you this evening. It was great to meet you guys today. Thank you very much for tuning in here tonight. Let's see, Mrs. Villarreal. Nice to see you back this week. And well, the one and only Angela Fox is here from Minnesota. My thoughts go out to you, Angela, and all of your neighbors there in Minnesota, because when we turn on the news and see kind of what's happening in your town there, it's just very scary times for all of us. No matter where you stand on these issues politically, you would have to admit that watching the news, it's not a happy time to see all the things happening now in Minnesota, and too soon after George Floyd and everything else. You got your hands full up there. So our thoughts are with you. Let's see. We've got Amber. Hey, Amber. Yes, indeed. You've got a transfer next week, and we are all very excited for you. Joining us first here on my Instagram was Amber. So you get a gold star for the day. Thank you for that. Victoria Lynn, good evening. Hello, Miss Rosa. Hope you're holding and hugging on your baby there. Bryn, nice to see you as well. Hi, Wendy. Marlena is there. Midgie Hi, Midgie says, hi, Dr. Fink. It's great to see you. Let's see. Bryn says, holding my 2.5-week-old daughter from a retrieval that you did at CNY. Golly, that is wonderful. I am so happy to hear that. Please send me a picture. Instagram me a picture there because I very much would like to post that. Congratulations to you and enjoy these diaper-filled and sleepless nights because they pass by really all too quickly. They really do. Mons, good evening to you. Victoria, howdy there. And let's see, I think hi, it's Rachel over here on the Facebook side. Hello, Dr. Randy. Rachel's from Tulsa office. Yes, indeed, I'm in Tulsa intermittently as well as in St. Louis for MCRM, but great to see you here this evening. Thank you for being here. Victoria asks, could a defect on a C-section scar cause issues in pregnancy? And so a defect in a C-section scar is actually something that is called an isthmocele or an isthmocele. Rarely it can cause issues, but really it's not known to be a big problem in most people. Now, if you had a prior C-section, then basically what that means is that you will, that the muscle of the uterus has been damaged. And it's been damaged by the incision made for the baby to be able to come out. Well, if I were to cut your bicep muscle here, and then allow that muscle to heal. When that muscle heals, it will not heal with the same strength as it would if it didn't have that scar on it. And the same thing really holds true as it pertains to the muscle of the uterus. And so when that muscle heals, it returns with about 80% of its strength. 80% of its strength, so not 100%. And what does that mean? It means that there is theoretically a risk in a future pregnancy that C-section scar can open up. And that's called a dehiscence, where the wound on the muscle itself of the uterus, or what we also commonly know of as a uterine rupture. And that may be a reason that many doctors are uncomfortable offering you a trial of labor after having had a C-section, or what we call a VBAC, a vaginal birth after cesarean, because of the risk associated with that scar opening up. And so that's really, kind of the number one thing. In theory, a pregnancy can implant in a C-section scar. You can have a C-section scar ectopic. And fortunately, that's a pretty rare thing. And most of the time, and in theory, that isthmocele that I spoke of is where there is a defect kind of on the inside of the uterine cavity as a result of where that C-section scar is. Now, most of the time, believe it or not, the C-section scar actually is, or where the place the incision is made in the uterus for the C-section is actually in the top part of the cervix. So it would be in what's known as the lower uterine segment. And when we, which means the top part of the cervix, so technically that's not where the endometrium is. So there shouldn't be an issue with a defect preventing an implantation in the uterine lining. However, occasionally an incision is made higher on the uterus instead of in the lower uterine segment, and that can be an issue, and that's really what an isthmocele is. That can be surgically repaired pretty easily. You just oversew it, but the less surgery you can have, the better. In general, I would say, gosh, we always pay attention to that C-section scar, but in most cases, fortunately, it does not actually cause you an issue there, Victoria. Tammy says 24-year-old boy-girl twins in 2001, Dr. Barry Rips. Wow, they're 24 years old now. Dr. Rips is my partner here at New Life Fertility, and he gave you twins in 2001, and that is, gosh, that's wonderful news. 24 years old. Can you believe it? I'll bet you still think of, well, I know I do, because I've got 18-year-old and 17-year-old are my two oldest. I have a 13-year-old as well. And even though they're all kind of big people now, I still, in my mind, are rocking them to sleep and putting them down in their crib. And I can only imagine that same thing holds true for you there, Tammy. Rachel asks, is the Tulsa MCRM office all in one for IVF? At MCRM, the egg retrievals are done in St. Louis and the laboratories in St. Louis, but embryos are transferred are brought back to Tulsa for embryo transfer. So pretty much everything else, all the monitoring in the embryo transfer can be done in Tulsa, but the retrieval itself, that one visit, happens in St. Louis. And oh my God, Tammy is saying, yes, in addition to the 24-year-old twins, you have a 3-year-old grandson. Thanks to your son. Holy cow, boy, time flies, doesn't it? And they say that the only reason that you don't murder your teenage children is because one day they will give you grandchildren. And I have to say, I've been very lucky with my teenage children and have only rarely, occasionally, only sometimes have wanted to murder them. So how about that, Tammy? That is just really awesome. Let's see what else we got going on here tonight. The Bama Gal, that's my mom in Mobile. Thank you for being here along with Dad. Howdy. We've got Zenaida in Miami. Thank you for being here. Good evening to you, my friend. Looks like Mrs. Charlie is here. Mike Ingstrom has joined. Let's see. Oh, Zenny says, hello to the most wonderful doctor I know. Thank you. You are very kind. And you're supposed to say the most wonderful doctor in the world, but I'll stick with the most wonderful doctor you know. I'll take that. That's just fine. Ms. C.R. Tyler, it looks like that says, hi to Aria as well. Victoria says, thank you. I have a transabdominal cerclage that doesn't come out during a C-section. Yep, I did have a couple of ectopic pregnancies on a C-section that I lost at 6 weeks in 2024. So that's why I asked about the defect, because I didn't know if they could be related. So yes, possibly so. You're talking about something that's called a cerclage. And a cerclage, C-E-R-C-L-A-G-E, if you are not familiar. A cerclage is basically a stitch that is placed in the uterus or placed somewhere in the uterus. Typically, it's in the cervix to kind of stitch the cervix closed. So there's something that's called cervical incompetence. And basically what that means is, we know that if you have a pregnancy, and the pregnancy is here inside the uterus. Oh, I got my funny pen there, but it's here inside the uterus. The cervix's job is to hold that pregnancy in. If there's an issue with the cervix can start to just open up on its own. Instead of thinning out and dilating, it can just go boom, and the pregnancy can come out. And that's what we know of as an incompetent cervix. And in that situation, we can basically put some stitching into the cervix here to help hold it closed. Now, some people have to have surgery on their cervix, let's say because of precancerous cells in the cervix. You may have to have a cone biopsy, or what we know of as a LEAP procedure. And so that is, and in some cases, the majority of the cervix actually can be removed. And in that case, we can do what's known as an abdominal cerclage. A stitch in the cervix, or a cervical cerclage, is typically removed at about 36 weeks of pregnancy. So usually about a month before your due date, that stitch comes out, because at that point you can go ahead and have the baby vaginally. Believe it or not, in most cases, the cervix does not just open right up. People, oftentimes then even still have to be induced because they don't go into labor after you remove the cerclage. But an abdominal cerclage is placed above in the event that there's not enough cervix to be able to put the stitch in. And the abdominal cerclage just stays there. It means that you have a C-section for future deliveries, and it just stays there. So yes, if you had recurrent C-section ectopics, or even one, it makes me wonder if that defect is a little higher than expected. So it just sort of depends on where that is, because you can have a cervix ectopic pregnancy, an ectopic that's in the cervix, and so it just depends on whether that was in the part that's called the lower uterine segment, or whether indeed it was higher. That is something that can be surgically repaired. But gosh, Victoria, that is a tough thing to have to go through, losing that pregnancy at 6 weeks, and I sure am sorry to hear that you had to go through that. But it sounds like you've been through an awful lot, and yet you persevere. And that's actually going to be what I am going to have a little post I'm going to put up tomorrow, just about perseverance, about staying with this process, even when it feels like the last thing you want to do is stay with this process. There are a lot of times that you may come upon yourself and say, I've just had enough of this, and the best thing I can do is just walk away. Well, I'm here to say I don't know that that's true, and we'll talk about that a little bit more tomorrow. Keep an eye out for my post on New Life Fertility and on Randy Fink, MD. Let's see what else we got going on here. Ms. C.R. Tyler says, hello to my favorite doctor. Oh, there you go. Yes, thank you very much. What are your thoughts about adding NAD plus injections for diminished ovarian reserve? Well, it's a loaded question, my friend. It is a loaded question. I would say, you know what? Certainly it can't hurt. So NAD plus is something that basically provides energy to our cells. And the thinking is that, well, if you've got diminished ovarian reserve, then you can potentially, is there something that you can do that may be able to improve the quality of your eggs? So maybe stabilize some of that age-damaged DNA. And so the thinking is, well, yeah, NAD plus may be one of those things. It's commonly used in the anti-aging community. Now, I've seen NAD plus as something that can be used orally, and I will say, like, as just a vitamin. I don't think that does anything. I really don't, because it has to go through the stomach, and it has to get absorbed, and has to get into the bloodstream. And I really just haven't seen that sufficient evidence telling me that NAD plus orally makes a big difference. It's usually in the form either of an injection or an IV infusion. There isn't great evidence to say that it makes a difference in terms of egg quality, even in someone who has diminished ovarian reserve. Now, we have some other potential interventions for ovarian reserve. Intra-ovarian PRP, or platelet-rich plasma, is something that we can sometimes use. And we're getting more attention to a medication that's called sirolimus. Sirolimus, also known as rapamycin. This is a medication that helps to stabilize some parts of our cells that begin to come apart as a result of aging. And that is especially true at the level of the egg. Rapamycin helps to stabilize that. It's an immune modifier that's typically used in folks who have had a transplant, who need some immune suppression. Well, taken in the short term, it has been shown to improve many of the things that we look at when it comes to egg quality, and in fact can improve high-level embryos, and may even improve the live birth rate, particularly for women with lower ovarian reserve. So I personally have started using that in my practice, and I think it is definitely worth looking into. So I have a few people who are using it now. I intend to be using it a little bit more. I will say that the evidence on it is very early. So it's not that it's certainly not a standard of care. But if you want to read a little bit more about it, look at rapamycin, 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 and IVF. Google that, or rapamycin and infertility, and see what you come up with. But my read of the evidence is that it actually probably does seem to make some difference. Let's see. Rachel says the doctor recommended me with a donor egg, but I want to try my own egg. Is that possible? And the answer is yes, it is definitely possible. Usually when we say, gosh, you should start thinking about a donor egg, it's because in our experience, it's a very tall uphill climb for you to be able to be successful with your own egg. And that is very commonly the case when we are older than about 44 years old. It gets very, very difficult to successfully achieve a pregnancy through IVF. But there is no reason that you can't try, because we do the medication, we see what we can get, we try to retrieve eggs, we fertilize those eggs, and it's worth trying to make an embryo. And if that's the right choice for you, then I'd say absolutely make that choice. The real question is, okay, well, what are the costs of doing that? Well, there's definitely a cost of the IVF cycle, right? But in addition to the costs of these things financially, there is very definitely an emotional cost to everything that we do in the fertility world. And most of the time, what we hope is that we're doing a treatment that has a hope of success. And so we really like to lead you down a path towards something that's going to help you reach your goal of walking away with a baby. And so that's why sometimes we're not it may not seem super enthusiastic about you using your own egg, because what we want is for you to have a baby. But if it is meaningful for you to try, then I'd say absolutely. I have done countless cycles like that for people who just need to see for themselves whether it's going to be, what the outcome would be there. So I would say, Rachel, I think it is definitely worth a try. And I'm happy to talk to you about that as well more. I can see folks here at New Life Fertility and at MCRM. I do MCRM consults every Friday afternoon, so feel free to ask for me. We've got Kim here as well, a 33-year-old lady. Howdy. 3 kids with the same father, normal pregnancies. I had a tubal ligation and then a reversal. My new partner now has 5 miscarriages. All have come back normal. I don't know what to do. All right, Kim. So I'm a little bit confused, and so let me see if I can clarify. You're a 33-year-old female. You had a tubal ligation and then a reversal, and now you have a new partner. You say your new partner has had 5 miscarriages, so I'm assuming that means that your new partner is female. There is a workup, and so I'm not sure exactly what sort of treatment that you're doing there, but there is definitely a workup that we do for folks who have recurrent pregnancy loss. It involves looking at some blood tests to see if there is something that is in your body that is trying to stop you from being able to stay pregnant, or in her case, her. If we usually look inside the uterine cavity, make sure there's nothing structural, and we think about some different tests in the immune system or some different treatments in the immune system. And there's also a question about the embryo itself, because let's say that your partner was 45 and had, day 3 embryos. The odds of those being successful are very low. But it sounds like this partner had miscarriages. Now, if this was a male partner and the female partner of your new male partner had 5 miscarriages, that may not necessarily relate. So I think it really kind of depends on exactly what the situation is. But yes, we typically take a deep dive into what all's going on in the body that may be contributing to these miscarriages. In some cases, we can find something, and in some cases, we have to conclude that the issue is autoimmune, and then we have some different treatments we can offer to try to quell some of that immune response that may be trying to stand in the way of the pregnancy. Let's see. Hi to Gradle and Rashmi. Hello, good evening. Angela Sack is here tonight. Hello, Angela. It says, do you sometimes decrease gonal in the middle of a stem cycle? Does that help follicles grow more equally? The answer is yes, absolutely. So when I do cycle management, when we're doing IVF, and really at every juncture, every time we get an ultrasound and a blood test, every time we do a monitoring visit, I personally look at, or at least attempt to look at those results. One of our providers always does, and if ever there's an issue, it's always brought to our attention. And the reason for that is because we like to follow these cycles very carefully. We take great pride in how we manage people's cycles individually. There is no one size fits all. So in some cases, yes, absolutely, we might want to slow down some of the stimulation that comes with that gonal F or that FSH hormone. So that may mean that you're growing a little too fast. And, the ideal time of stimulation is between 9 and 12 days. And so let's say that you have really shot ahead like a turbo growth kind of thing, or you have just a ton of follicles and your estradiol level is going way up, then we would absolutely dial back some of that stimulation so that you will grow more slowly and so that we don't excessively hyper stimulate the ovaries. Does that make sense? So yeah, it's not unusual at all to say, let's drop back a little bit in the interests of safety and in the interests of quality. So there we go. Hey to be nitty. Fink. Oh, Ruby is here. Hi, Ruby. Let's see. Ria 12111 says, my name is Maria. Hello, Maria. Question. My daughter went through chemotherapy and a transplant. So at 23, she has no hormones anymore. She had an aggressive cancer and harvested her eggs after the first chemotherapy and got 14. Well, that's fantastic. So she got 14 eggs from a cryopreservation. Do you think the eggs will be okay after having one dose of chemo? And if so, what's that process look like if she wants to have a child? Well, so the actual recommendation is that for the safety of the DNA that's in the eggs, that you ideally you wait for a year after having your chemotherapy before you get your eggs retrieved. Now, that is just not always possible. It does not always work that way. Because it may be a surprise that you find out that, oh my God, I have cancer and I have to have my chemotherapy and we have to get into this kind of right away. And you may not have time to do some egg freezing. So you get what you can. And so she did her treatment, she got her eggs, and now she's sitting in a good place with all 14 eggs. Let's talk about what happens next. But first, before we do that, I would like to jump into what I do every Tuesday afternoon at this time. I call it the 5:30 Fuzzies with Fink, the 5:30 Fink Fuzzies. And it's not talking about my hairdo or my beard. It's talking about sending out good wishes. So pretty much everyone who is involved in this podcast, who is watching, has undergone some kind, either they or someone close to them has undergone some kind of fertility treatment in all probability. And in that scenario, you know what it's like to feel alone. You know what it's like to be frightened of not knowing the outcome and what's going to happen next. You know what it's like to make a call to your fertility practice only not to be able to talk to someone, to have to leave a message and get a call back later. These things are very frustrating. And not only that, they're demoralizing and they're just plain old scary. Life is a scary place. It's scary enough to have to do the things that we're doing in fertility, notwithstanding how scary the rest of our worlds can be sometimes. We all can have difficulties in relationships. We all can have difficulties in the workplace. We all can have difficulties at school. No matter where we are, these troubles seem to mount up, and how we deal with them can be a direct reflection of how we're going to feel about our own self-esteem and about our own lives. At this point in the program, I like to just take a moment because I know that each and every one of you out there would likely bend over backwards to help someone else on this program in need. Given that the logistics of being able to kind of touch everybody or for everybody to touch everybody here are such that, well, that's clearly not going to happen. Social media isn't really meant for that kind of thing. But you know what? We can break the internet right now if we all just take a moment and stand together as one community and send out our good wishes, our good vibes, all our positive thoughts to everyone out there who needs those thoughts tonight. Whether it's a sickness in your family or the loss of a loved one, the loss of a pregnancy, or just the ups and downs of fertility treatment, now's the time to say, you are not alone. We are all here for you. And tomorrow is a new day. And like I say at the end of every program, that new day is full of all new adventures. The world can be a kind place, and it's people like you that make the difference. And so thank you for participating in the 5:30 Fuzzies with Fink. Get your friends to hop in next time, would you? Even if it's at 5:29 for 2 minutes, so that the more people we can have here, let's break the internet with kindness, send out those positive vibes, do something nice for a stranger, because that, my friends, is how we are going to change the world and change ourselves while we're doing it. All right, that's the Fuzzies with Fink. Thanks, man. Okay, Rhea. So now what happened? She had chemo. She got 14 eggs and wants to know what's next. The first thing I would say is you want to make sure that she's medically cleared. Make sure that her oncologist says that she is good to have a baby and that everything can proceed. The first thing to do is, if she has a partner in her life, then we want to have that sperm checked. If she would like to be a single mom by choice, a sperm bank is a great place to start because you can select a donor based on any number of criteria that you wish. That sperm is sent to the lab. The eggs are thawed. Now, when we thaw eggs, we may lose some of those eggs. You know, if we have an embryo and we freeze an embryo and then thaw that embryo, I expect, probably at least a 95% survival rate on thawing an embryo. But with an egg, it may be 80 to 85%. Because remember, an egg is just a single cell. It's very, very fragile. So we'll lose some of those 14 eggs perhaps. But nevertheless, once they are thawed, then they are fertilized and we create embryos from those eggs. We grow those embryos up to whichever point it may be. Most places will grow up embryos to the point of what's known as a blastocyst, which is a day 5 embryo. And we do that because that day 5 embryo has passed a metabolic milestone. It has survived to the point where we know that it's going to have a higher probability of being able to get you a baby. And ultimately, that's what we're after here. We can then freeze those embryos and get her body ready. Now, it sounds like if she has no more hormones anymore, that the hormones kind of wiped out the ovarian hormone supply in her. And that's okay because the uterus does not age at the same rate as the ovaries do. So we would simply give her some hormone, typically some estrogen, build up that uterine lining, get that ready so it's nice and thick and warm and juicy. Give her a little extra progesterone, for about, depends, anywhere from 5 to 7 days. And then we take that embryo and we place it inside her. We continue to give her some hormones until about, roughly 9 or 10 weeks of pregnancy. At 9 weeks of pregnancy, the pregnancy's placenta takes over for making the hormones. So the ovaries really aren't doing aren't doing very much at that point. But up until then, it's usually the ovaries that are giving the hormone. So after an embryo transfer in a medicated cycle, like for someone who isn't making their own hormones, we would give her all the hormones that she needs. And I have no reason to think in that scenario that her body can't hold a pregnancy. She can't carry a normal pregnancy. And it would be really, for the most part, based on what you've said, just like every other person who gets pregnant. So, Maria, I am certainly excited to hear that you, my friend, may become a grandma. So, fingers crossed there, and all the best to your daughter. If we can help, by all means, please do let us know. Hi to Bree. Thank you for being here this evening. Rachel asks, how much is the cost with a donor egg? So I will tell you, a great place to look at donor egg and the programs offered, especially in the St. Louis area, is a place known as Matching Miracles. And you can look at matchingmiracles.com to see kind of what sort of programs they offer. Call them on the phone, ask for a consultation, and you can get some real detail about what happens next. So you say that your AMH level is 0.2. May I ask, Rachel, how old you are? Because that makes a difference as well. And I'm going to wait till you reply to that one over here on the Facebook side, and then I can give you an honest answer. Hi to Adage, I think that says, and Shannon, nice to see you. Disney stuff with Matt. I like that name. It's a mouthful, but I like it. We were just talking about Disney today, in fact, that, Disney actually will come in and do a customer service workshop for offices, to kind of teach them teach places the Disney way. And I wish we could do that. I would love to be able to do that. I'm just not sure how good I would look in the mouse ears. That may be the problem. Matt, you know what I'm talking about. I think you do. Rachel says, I am 41. So you're 41 with an AMH of 0.2. That just tells me that it's going to be difficult to stimulate your ovaries. That doesn't mean that you don't have a normal egg inside. And so what you might consider doing is something that we can call, it's a trial cycle, or maybe some people call it a closure cycle. See how it works. I would say it is going to be an uphill battle using your egg. Just based on the fact that at 41, many of our eggs, in fact, probably most of our eggs, are going to have chromosomal abnormalities, because unlike the sperm that comes out today that was manufactured in his body 3 months ago, every one of those eggs has been there since the day you were born. And over the course of those 41 years, the DNA in those eggs becomes less stable. And we lose eggs to the process of aging, and the DNA becomes less stable. And those are the two reasons it gets harder for us to have a baby as we mature. But you know what? I've seen 41-year-olds with AMHs of 0.2 get pregnant from IVF with their own egg. It's just not an easy process. It is not likely to work in a single cycle of IVF. And so you just kind of have to be prepared for climbing the uphill battle. Now, the difference is if you were going to use a donor egg, I won't say, oh gosh, it's super easy, but it is a much simpler process. And the odds of you walking away with a pregnancy when using the donor egg are extremely high, because those donor eggs come from people who are in their 20s with very stable DNA. So that's really what you have to weigh out there. There is a risk to having to climb that mountain, and it's an arduous climb. It's an arduous climb for which there is an uncertain outcome. Whereas if you use a donor egg, the outcome is fairly certain that you will create an embryo that's going to get you a baby. So it just depends on, sort of how you feel about that. Hope that answers the question there, Rachel. Hi to Pensacola Wellness, and looks like a sing party of 3. Hello, I like the name. Reagan Hartwell, hi, nice to see you this evening. We talked a little bit more about, we were talking a little more about, a little bit before about rapamycin. And Angela asked the question, how do you take it? It's an oral medication. It's a pill. You take it, generally speaking, I start you take it for about a month is really what you do. So I usually start at about 10 days before before the expected start of your stim. Did I say that right? No, I'm sorry. I start that 21 days before stim start, thinking that your stim start is probably going to be roughly about, average of 10 days. And that's the kind of timing we use. If it's a little longer than that, that's okay. If it's a little less than that, then that's okay. But really just in the few weeks leading up to the stim start, I have not seen evidence, at least in the studies that have been published, that's the way they used it to good effect with a good outcome. I have not seen anything that looks at use of it long term. In fact, I had a patient who I talked about, and I really thought, you know what, I want to go ahead and put you on that medication. And I think I saw your name a little bit ago. And then I changed my mind because actually reading a little bit more about it, people were not on it for the long term. People were really on it just for the short period leading up to, because theoretically it can have some side effects, and everything has side effects. What are those side effects to rapamycin? Well, they say it can cause fatigue. Taken over the long term, it can cause immunosuppression because it's an immunosuppressant drug, but you're not taking it for the long term. You didn't have a kidney transplant. We're just trying to boost up your ovarian wellness there, your egg quality. And the one thing that I was worried about is that it said it can cause mouth ulcers. And I'm like, you know what? Maybe this is not ready for prime time. But the more I read about that, the more I saw that it really has more to do, that scenario, with people who are taking it long term. So I feel pretty good about it, actually, and I've had good reports from my patients who are taking it. They really don't feel anything that's untoward. And it's a lot cheaper than Omnitrope. Now, Omnitrope, or human growth hormone, is very controversial because there's some studies that show that it helps. There are other studies that show that it doesn't, but everything tells you that it's damned expensive. Even from the discount fertility pharmacy is probably $600 for the vial. That's a lot of money without a guarantee of an outcome. Now, many practices use it routinely. I actually like it. I've used it a lot, and I think it does make a difference in the right person. And that's the problem with some of these studies. You just don't know exactly who the right person is. And so, we use it across the board, and many people to try to improve what we think is going to be an egg quality issue. Maybe it helps, maybe it doesn't. I think it does, but sirolimus or rapamycin costs about, I think I looked at it on GoodRx, which is okay. If insurance doesn't cover it, it's like $40. Is the cheapest one in the local pharmacies. Have you used GoodRx before? GoodRx.com will help you get discounts on prescription medications that sometimes may be cheaper as a self-pay with their little card than what your insurance is charging you, or what you're paying the pharmacy for through your insurance. So it's nice to get the GoodRx app, and you can just check every one of your prescriptions. That's what I would do. Okay, let's see. Bear and Dove cookies. Ooh, I like the sound of that. Bear and Dove cookies. I'm kind of a cookie fiend, cookies and ice cream. I think we should have cookies and ice cream every day at lunch, don't you? I think we should have a cookie and ice cream buffet. And that will just make everybody happy, especially me. And just to be clear, it is all about my happiness here. Just we're all clear on that. Shada, nice to see you. Yes, I miss you too. I haven't seen you around for a while, but I hope all is well and that you are moving towards your dream, my friend. And please send my fond regards to your wonderful husband as well. Hi, Morgan. Actually, Shada had some more to say. We wanted to bank a couple more embryos. However, not a good outcome so far. The first one, they retrieved 7 eggs, 4 fertilized. 4 made it to blast, but only 1 came back normal. And in the second egg retrieval, they got only 1 egg. Interesting, Shada. Gosh, you have been through, you have really ridden the roller coaster here, my friend. And my hat goes off to you. And so, yeah, please, by all means, our thoughts are all with you. And my personal warm regards to you and your husband. Hi, Shaylin. Let's see. Oh, actually, I got more. So Angela says, thank you. Would that also apply to Menopur? Decreasing Menopur, is it mostly only with the FSH, not the LH and FSH? You can go either way, to be honest with you. But most of the time, it's just easier to dial back because Menopur comes in 75 increment vials, right? So if you're dialing back, you're going to cut back 1 whole vial. Whereas with Gonal-f or Follistim, you can literally kind of dial the pen. You can change your dose just a little bit more easily, and but you can't actually go either way. Shada, I'm sorry, I didn't see that you had said on the 3rd egg retrieval had 14 follicles and was very optimistic, but they only got 3 eggs, only 2 fertilized. I'm 37, husband's 42. Is this an egg issue or a sperm issue, or is the body just exhausted? Should I give it 1 more try? That's a tough one there, friend. It sounds like you're getting diminishing returns. And I wonder why that is, because you started out really so robustly, doing very well, and really came back with, kind of amazing results on your first PGT. So I wonder what's happening there that's causing you to get these diminishing returns. This might be a reason to maybe think about using something like sirolimus or rapamycin, because it might just help your egg quality, might help your outcome. So presumably better egg quality means that you will get more eggs, because if the eggs have unstable DNA, you may produce those eggs, you may not produce those eggs, you may have empty follicles, which is what it sounds like, because I think you said here 14 follicles and only 3 eggs from that. So that's a lot of empty follicles. That's telling me there's an issue there. There's an egg issue, something going on with your ovary for sure. So Omnitrope, sirolimus, these are both good things to consider. And of course, the protocol that we talk about for supplements, it's a handful, I know it, but I do think that stuff can make a difference. So yeah, if you were going to give it another try, I would say I wouldn't want you to do the exact same thing. I would want you to do something different, because, they say doing the same thing repeatedly and expecting a different outcome is the definition of insanity. Now, I don't know that that's necessarily true, because in this business, you can do the same protocol twice in a row and have completely different outcomes with IVF. And that's just kind of the way the human body works. But I think you've done it enough times and seen the results are not going in the right direction, that I would want to take a look at that and say, what can we change here? What else can we do to try to improve your egg quality? And one of the things I would say is, probably if you're not using Menopur, if you're using just HCG LH, that may be one thing, because where you're doing your retrievals, that is their favor. But I think that's kind of worth looking at. Bree says, what leads to poor blast development, and any recommendations to improve the outcome? Pardon me. We are having fertilization rates at 82%, but only 3 blasts develop. So 17 out of 21 eggs fertilized, but with only 3 blasts. So, the first thing that I would kind of wonder about here, so that says to me, okay, in all probability, yes, that is an egg quality issue. And so I think about, gosh, what are the things that we could do for egg quality? And we're talking about omnitrope and we're talking about sirolimus as possibilities. I would also, Bree, really want to know what's the situation there with sperm. What did the sperm really look like? What was the morphology? Did you do DNA fragmentation? Because in many cases, when we have abnormal sperm, what we find is that the sperm themselves are just unable to fertilize the egg. You're getting good fert rates, but then when the embryos aren't growing, that tells me that there's something chromosomally in all probability that's happening there. There's something about the way that genetic material is trying to divide that is not allowing for the continued growth of those embryos. And depending on your age, Bree, answer me, how old are you? Just throw that in there. That really tells us about what we would expect in terms of blast rates. But DNA fragmentation may be one of those things. And so being able to select better sperm is one way to do that. How can you make? Oh, and Bree, you're 32. So yeah, I would expect that your blast rate would be much, much higher than that. I would expect about 80% fertilization at 32. Of those, I would expect about 70% to make it to day 3. And of those that made it to day 3, I would expect 50 to 60% of those to make it to blast. So, yep, you are not getting there. Semen analysis, DNA frag were normal for my husband. We're taking omnitrope. So I might consider adding something like sirolimus. And I think the other thing to think about is, okay, how are you selecting sperm? So if you're at MCRM, MCRM offers up to 3 different sperm preparation methods. One is using what's called Zymot, and Zymot or Zymote is a little obstacle course that you run sperm through, and the best ones come out the other end. Then you take that sperm and you can do some other stuff. You can put them on some beads. These beads are like what the eggs are like, and so the ones that stick to the beads are typically the better ones, and so you can get sperm from that. Then you have a third cohort. You can do something that's called Pixie. Pixie may also help to select better sperm. And I would say, it's worth talking to your doc there about that. I would have to think that this is likely an egg issue, but you still want to make sure that you're getting all the right sperm there. Yeah, that's a tough one. And, to be honest with you, some people just have these egg issues because we don't know really why. Is it because of something in our drinking water? Is it because of, chemicals in the food we eat? It may, in the air that we breathe. It's probably all of those, for the same reason that when I look at folks at the AMH, at your AMH level. Well, okay, so the AMH is the marker of your ovarian reserve. And each little egg in your ovary is surrounded by some cells that make this AMH hormone. So the more eggs you have, the more of these cells you have. And the more of these cells you have, the more AMH you make. And we can measure that amount of hormone, and we can plot it out on a graph and see where you are relative to other people your age. And when we do that, and I do that every single day with every single patient who's coming through the door here, I often find that compared to average for age, many people's AMH more correlates with an age that might be 5 or 7 years older. And that's because, all right, the ovaries often age at a rate that's faster than the rest of the body. But why? My only answer is chemicals. I think it has to do with chemicals. Endometriosis certainly can be a reason for that as well. But there's not a whole lot we can do for that right now. But I would say you want to throw in everything that you can to try to improve egg quality there, Bree, egg quality and sperm quality, because it looks like that is most likely an egg issue. And again, I wish we could do a test and say this is exactly why, but then that would also say, well, if we knew exactly why, then there'd be something that we could do to fix that. And so far, we're just not there yet with the science. I always say, I wish that we had some way to give you medication that says, okay, we'll take those normal eggs. You can keep the other ones, okay? You keep those for yourself. We just want the normal eggs. Well, my guess is that at some point, the science will be there when we can look at an egg and make some determination, possibly based on AI, or something that's going to end up being pretty technical, to say which one is most likely to get me a baby. Let's see what else. Okay. Talking again here to Shada, they retrieved 9 follicles, but only 3 were eggs. Others had fluid around them and degenerated. Does that mean we triggered late? Not necessarily, no. That may just be that they were kind of cysts. And a cyst in the IVF world means that it is just a little fluid-filled sac that doesn't have an egg in it. Now, if you already ovulated or you triggered late, then typically what happens is that little sac starts to collapse, and sometimes it'll even fill with blood. So we can look at that and actually, see that that's the case. I think that is that's just kind of an ovary issue. So I'd want to know a little bit more about the timing of all this. Hi to Lisette and DH and M Wonderland. Kowser, nice to see you there, my friend. And Maria says, oh, she's 27 now and getting married soon. So yeah, you definitely have a grandkid in your future there, my friend. I'm so glad that she made it through that whole chemo thing, because boy, that's a tough one. Let's see, is a grade 6 BB embryo too fragile and not a good one? So a grade 5 embryo is a hatching embryo. Grade 6 is fully hatched. And so there is some evidence to suggest that when it's fully hatched, it may be fragile. And as a BB, it's kind of a fair graded embryo. So I wouldn't say that is probably your best embryo. That may be something to transfer as a second embryo along with another one. Now that's a euploid embryo, and you're not supposed to transfer more than one euploid embryo. But that embryo, I'd say, it may be a little iffy. And so sometimes transferring 2 embryos can increase the probability that one of them will stick. And I would say that's a good second tier embryo based on that. Hi, Red Bear. Hadn't seen you around for a while. Good to see you, Dragon. Nice to see you. Hey, Noodles. Do you recommend an HCG wash the day before a medicated FET? The HCG wash is where we place some of the pregnancy hormone inside the uterine cavity in order to upregulate or to turn up the volume knob on some of those receptors, those pregnancy receptors. It certainly can't hurt. It has a cost. Is it specifically helpful in the general population? And I would say no, it's probably not. It is helpful in some people, but the question is, in whom is it helpful? So given that the cost of it is not overwhelming, if you are logistically able to do it and it is offered, I'd say there's no harm in doing it. Does that make sense, Noodles? I hope so. How many milligrams of rapamycin are we talking about? It's 1 milligram per day. 1 milligram per day, starting 21 days before you start stim. Hey to J. Palmyro. Is that who I think it is? Can you take sirolimus with rapamycin? Oh, well, it's the same thing. Rapamycin is kind of a brand name. Sirolimus is the generic name for rapamycin. Well, folks, it looks like we are going to run out of time this evening here. I am so pleased that here's a quick question. Mohi says, or Amal says, is blood pressure medication safe to take during embryo transfer? Yes, but I would want you to be on a medication that you can be on during pregnancy. So most commonly, that's something like labetalol, or a beta blocker is a great place to kind of start with blood pressure medication. But yes, we want your blood pressure to be well controlled at the time of your embryo transfer. Folks, every Tuesday evening, this is the place I would love to see you. And I'm so honored that to have the privilege of your time tonight. It's my favorite place to be all week long. I love being able to help out. I love seeing the same names and new ones showing up here. It just really means the world to me to know that you're willing to join us and be a part of this community. This whole fertility thing is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite that chapter together. Every step forward with love, every step forward with kindness. There's not enough kindness in this world. And every step forward with hope. Because tomorrow is a new day. And by gosh, it's full of all new adventures. So until next week, thank you so much for being here. From Pensacola, I'm Dr. Randy Fink. Good night.